So today, on June 4th, I'll give the numbers to start with, and then we'll talk through some more of the epidemiology. So we have 5 new cases who have tested positive for COVID-19, and as of today, we'll also be including our epidemiologic link cases, and we have 4 of those. Those are all cases that we have been counting since May 19th, the restart date. So in total, we have 9 cases in BC, bringing our total to 2,632 people in BC with COVID-19. I will say with these 4 epidemiologically linked cases, they are all recovered, so they are not active cases at the moment. So that includes now in our health authorities, we have 909 people in Vancouver Coastal Health, 1,334 in the Fraser Health Region, 130 on the Vancouver Island Health Region, 195 people in the Interior Health Region, and 64 people in the Northern Health Region. We have no new healthcare outbreaks, and 6 active outbreaks, all in long-term care, continue. As of today, we have 340 residents and 217 staff who have been affected. We do have one new community outbreak, and as you know, as we've been restarting, we've been monitoring very carefully in our community. This one is at the Beresford Warming Centre. It's a shelter in the Fraser Health Region, and there are 3 confirmed cases, and we're hopeful that that means that the transmission has been limited, and most of the cases are in staff. Public health teams from Fraser Health are on site and actively investigating and tracing anybody who may have had contact. We also continue to monitor and support at the other community outbreaks that we have ongoing. So in BC today, we have 201 active cases. Of those, 26 people are hospitalized, 6 of whom are in critical care or ICU. And another positive note today, we have no new deaths in the province today. So 2,265 people have now fully recovered from COVID-19. I'd now like to turn our attention to our going forward presentation. So this is an update on the epidemiology in BC. I'm just trying to get myself organized here so I can see the slides. All right. So we've entitled this How and Where the Virus Has Affected People in British Columbia, and we are going to be presenting some geographic data as well, and we'll get into it. So this is a curve you've seen before. This is what we call our epidemiologic curve of the confirmed cases in British Columbia. So we now have extended to the end of May on this curve, and what you can see that's slightly different from what we've presented in the past is that we have our epi linked to those purple bars cases noted as well, and as I mentioned, we started that on May 19th, and we will be continuing to monitor that. So epidemiologic link cases are cases where somebody is a close contact of a person who has tested positive for COVID-19, and there's often there can be many reasons why they may not have been tested, whether they had mild enough illness or they were identified at a time where their illness was mostly recovered, or that they weren't able to get out of the house and go to a place where testing was available. So those are numbers that will be helpful for us and cases for us to follow systematically going forward. The next slide gives you an idea of a smaller geographic breakdown than what we have been presenting so far. So we've been spending quite a bit of time making sure that we have this data available in ways that represent the impact of the pandemic here in British Columbia on the different geographic areas. And I will tell you that this is by what we call health service delivery areas, smaller areas than the health authority areas, but not as granular as I know many people would like. And we are working on how we can present this data in a way that gives you a better representation of the impact on smaller communities around the province. And we will be having that more granular data available publicly in the coming weeks. So this does tell us, if we look at the pink graph, the pink picture tells us that there have been no communities in British Columbia that have not been affected by COVID-19. Some of them more so than others. And this is not a surprise for any of us. We know that the cases that we've reported here that have tested positive, people who have had a test, we know as well that there was a period of time, particularly in March, when many people were coming back from travel, where we did not have testing available as widely around the province, that there were many other people who also had this illness but are not yet represented in these numbers. And part of our strategy to understand that impact is to ensure that those people will be followed up on with serology testing as soon as we are confident we have a valid test. So it does tell us that, as anybody who's been watching will know, that the Lower Mainland was disproportionately affected by COVID-19 with the outbreaks that we've had in long-term care, in Vancouver Coastal, in the North Shore, and in the Fraser Health Region. This information is presented as a heat map by rates, so the number of cases per 100,000 population. On the right-hand side, the purple map is the same information presented as the number of cases per 100,000 population over the last 2 weeks. And as we can see, the number of cases has dropped dramatically across the province, and the hotspots remain in the same areas, particularly in parts of Fraser Health. And those are related to the outbreaks that we have seen in our communities, in long-term care, over the last few weeks and months. On the next slide, we'll talk a little bit about who this virus has been affecting. And so this is the COVID-19 cases by age and the proportion of people who are affected within each age group, and the numbers on the top of the bar give you the number of people in that bar. So the things that strike us about looking at the age of people who have had the disease is that the majority of cases are people between the ages of 30 to 60. And really that reflects a lot of our working population, particularly healthcare workers. We also see that there's a very small proportion of young people who are affected. We had 26 children under the age of 10, and that's about 1% of the cases, and 51 young people between the ages of 10 and 19, so about 2% of cases. So that is something that we have seen reflected around the world as well. So knowing that the majority of our cases are young adults between the ages of 30 and 60, as I've said, the next slide tells us a bit more about the impact of the disease on people who do get infected. And this slide reflects the fact that it is as we get older that we're more likely to be hospitalized, to need ICU care, or to die from COVID-19. So the first set of bars on hospitalizations reflects that it is in the 60s, 70s, and 80s that people are more likely to end up in hospital. We do have had two children under the age of 10, which is about 7% of those children, but a very small number, and one person between the ages of 10 and 19 who are hospitalized. In the middle set of bars, we can see that the age moves up for those who required care in the intensive care unit to mostly be clustered around people in their 60s and 70s, with a number of people in their 80s and 90s as well, including some that we know their stories that were in intensive care and went home, which is the good part of that story. There were no people under the age of 20 who required ICU care. And if we go to the one bars on the right, the people who have died from COVID-19, again, we see that it's heavily skewed to the older age groups, so our elders and seniors. And you can see that there's a big difference between people who have died and people who ended up in hospital. And much of that reflects the fact that this has caused many deaths in older people and our elders in our long-term care homes. Importantly as well, we've had 2 people in their 40s who have died from this virus, but nobody under the age of 40. And that is important for us to remember as well. Next, presenting some information, and I've talked about this before. So this is the number of people who have been infected with COVID-19 by sex. And as we can see, overall, it's fairly well balanced. Slightly more women than men have been cases of COVID-19. And then in the next slide, it shows us the severity of illness. And this is something that is that we've seen in British Columbia that reflects what we've heard in other parts of the world, where men are much more likely to have more severe illness that require hospitalization, ICU admission, or to die from COVID-19. And about 2/3 of those cases, hospitalizations, ICU care, or deaths have been in men compared to women. And this is something that we've seen in many other countries, and we've talked about the biological reasons why this might be. We still do not have all the answers to that yet. And it is interesting because the numbers for Canada are slightly different, and those are heavily driven by numbers of people who have died, in particular in Ontario and Quebec, where there's a much more balance and slightly more women than men. And really, I believe that reflects the number of women who are in long-term care homes and the numbers of deaths that have occurred in that setting. Finally, just to give you a sense of the differential impact on our elders, this slide presents the proportion of people within each age group in the population, and we've presented this before. So we can see that about 10% of our population in BC are children under the age of 10, and only 1% of our cases are in that age group. And if we look up at people over the age of 90, we see that about 1% of the population are people over the age of 90, but that's over 20% of the people who have died from COVID-19. The next infographic, this slide presents some information that I'm very proud of. It reflects the work that has been done by the public health teams in British Columbia in doing the investigations, and put some numbers to our case and contact tracing that we've been doing in British Columbia over the past few months. So before March 15th, to start on the far left-hand side, we had 1,257 case investigations, or investigations that were initiated by public health. And that includes 1,000 history and contacting the contacts. So when I say on average they had 11 contacts, that means that many of them had, many people who were infected had very few. They had 1 or 2 or even none, whereas some had many, and it was a much more detailed investigation. Of all of the 1,100 people plus who were contacts, close contacts of a case, only 2% developed the illness themselves. So that's an important measure for us to understand as well. After March 15th, when we put in many of the public health restrictions, we had considerably more cases. That was at the period of time where our outbreak was increasing, and we had 11,000 public health investigations, over 11,000, and over 8,665 contacts who were traced at that time. What we can see from this is once the restrictions were put in place, people had far fewer contacts, which made our work much easier. So there was 3.6 on average for every case. And again, 98% of those people were reached within 24 hours, a really important feat. And it speaks to the teams that we have doing this important work. And after that, as we know, people had much more close contacts with their smaller circle or their bubble. So if somebody introduced the virus into their contact network, they were more likely to be exposed and to have the disease. And 7.4% of the contacts that we traced with these investigations became secondary cases, so became sick with the virus themselves. So that total tells us that over the 12,000 investigations, and I will say that this does not include the outbreak investigations that we did in places like long-term care. So it doesn't include those numbers that of people in long-term care or some of the other closed settings where we had outbreaks. But after we put in the restrictions and people stopped having much larger groups and gatherings, we had a third of the contacts. And this is how we broke the chains of transmission in British Columbia, by reducing the numbers of people that we had close contact with and not giving the virus a chance to move to large numbers of people. And we reached a very high percentage of those contacts in a very short period of time. And I really need to give kudos to the public health teams around the province who did this work and helped us break the curve. The next, I'm going to present some really interesting stuff that we've been doing. This is what we call genetic or genomic epidemiology. And this is some really leading edge work that has been done out of the British Columbia Centre for Disease Control with our laboratory team, the Public Health Lab and Genome BC. And it's work that we've been doing around tracing where viruses or bacteria come from to help us understand how people can be connected. And we've been using this type of analysis to help us with things like a tuberculosis outbreak that we had here in the province. But this is the first time that we've been able to rapidly sequence genomes to help us understand the trajectory of our pandemic in a very short period of time. So what you see here with all these lovely colorful dots is about 700 to 800 of the viruses that have been isolated from swabs taken from people, and the genome of the virus, so the RNA, the genetic material of the virus, has been sequenced to help us understand where it's closely related to. And what happens is viruses, when they replicate, they change slightly. This is not a very fast-changing virus, so we can tell where it's come from by how many changes there are in the genetic pattern. And then we share those around the world, and we compare, and we can see where somebody may have originated or where the virus may have originated that then came into British Columbia. And along the bottom line, we have a timeline. So our first cases came in British Columbia in middle of January when we first had a test for this. And they are this, what we call the B3 lineage, so mainly from China. Not surprisingly, that is where our importations came from, and that follows with our traditional epidemiology, where we knew people had traveled in from places in China, and the virus that we isolated is very similar to the ones that were coming from Wuhan province, for example. As we went along, we had a new introduction of a virus, a kind of the green one near the top, the B4 strain via Iran. And we know, you will recall, that was early in February when we had an unusual event, what I called a sentinel event, or an indicator event, and that was we identified a person who had not traveled anywhere near China, who had come back from Iran, and the testing that we did at the time showed that she did have COVID-19, and this was before Iran had notified the World Health Organization and people were aware that the outbreak was happening there. So doing the genome sequencing at the time helped us really confirm that, yes, this virus was quite different from the viruses that we were seeing coming in from China, and we had seen quite a few of them, and they weren't spreading too much. So we saw this new genome sequence come in, and it turned out to be very highly correlated with the genome sequences that were circulating in Iran once we had that information as well. So it was one way of helping us confirm those links. Finally, the next event that we had is some of these fuchsia colored dots, and what we call European-like and Eastern Canada. So the initial ones for us were ones that came from, that were introduced during a conference that was held in Vancouver, and we had a number of cases arise from contact in that conference, and one of the people that we knew was positive and had attended that conference had been previously in Germany during his incubation period before he became ill. And so the viruses that we were seeing that came out of that conference reflected their European origin, and they were more closely related to virus sequencing that we were seeing in Germany and Italy and France. We know from this genomic sequencing that was done, once we started to see many more cases come from that conference and being associated with that conference, and as you know, we had 87 at least in BC that we know, there were likely several people who had attended that conference that were ill, because we found 3 slightly different strains of a virus related to people who become sick in that from attendance at that conference. So this is a really nice way of helping us put together our basic epidemiology with understanding how people can be connected. And all of them were European strains that were slightly different. Again, it tells us the risk that we have of congregating together when this virus is circulating, even anywhere in the world. And finally, we have a whole cluster of cases that are related to what we call Washington State. So that's the A1, the turquoise-colored virus lineages. And those, of course, you will remember, were a lot of what was happening in Washington State very much affected our pandemic here in BC. And so with that, the next slide shows this in a slightly different way. And so this is, again, timeline along the bottom, and it shows that we had many introductions early on, but mostly they were linear. They didn't cause a lot of exponential growth, so they weren't being transmitted. And that is partly because people were self-isolating as soon as they got ill, and partly with the work that we were doing in public health to trace people and break those chains of transmission. What we do see is around March 10th, time frame there, we had an increase, a steady and rapid rise in the Washington State-like virus strains that we were detecting. And that really reflected people coming in from Washington State or us going back and forth across the border and bringing the virus back, and then it seeding outbreaks in our community and in our long-term care homes. The fuchsia, again, the European-like, again, we had a rapid rise in those around the same period of time, many of them related to the conference, and then transmission within our community here, and as we went forward, people returning to British Columbia and Canada from other parts of the world. So this is just a pictorial representation using the virus genomes that help us understand how our pandemic progressed here in BC. And finally, just around the same thing, this is the geographic distribution of where those viruses were found more frequently. So this is by health authority again, and the size of the circle reflects the numbers of cases that we're seeing in each area. So you can see in Fraser Health, there were a lot of the European, Eastern Canada related strains. We're in Vancouver Coastal, Washington State, and again reflects what we just talked about, how people coming in with the virus back and forth across Washington State seeded some of the outbreaks in Vancouver Coastal. And in other parts of the province, there was very much a mix. It was related to people who attended the conference that we're talking about in the north and on Vancouver Island, in the interior, also related to people returning from travel from many parts of the world. We know there was a number of clusters of cases related to people returning after cruise ships. Cruise ship outbreaks. We know we had clusters related to people, temporary foreign workers coming in from Mexico, and those are reflected in the other colors that are in those circles. So that's kind of an exciting and innovative way that we have been using the genome sequencing to help us understand the epidemiology in British Columbia, and we will be able to use it as we move forward through our pandemic to be able to pinpoint where people might have picked up their virus if cases arise in our community that aren't linked. All right. Next, we'll just go on very quickly to slides that you have seen before. So this is our curve, our pandemic curve. So these are the case rates. So the rates of cases per million population in British Columbia compared to the rest of Canada and to a number of other countries around the world. And we have, by the work that people have done here in BC, maintained a very flat case rate across and comparable to many other countries in the world, and certainly compared to many of our other provinces in Canada, particularly Ontario and Quebec. And the second part of that is looking at the rates of deaths per million population, and you can see Canada, the rest of Canada and a number of other countries compared to BC, and BC compared to a number of other provinces. And again, it reflects what we have done to try and minimize the impact of this virus on our populations here in British Columbia. So finally, I'm going to go through a number of the models, the first of which you've seen before, and it is to let you know what we have been watching and what we will continue to watch as we go through BC's restart. So we have been watching our mobility, where people are going, and comparing that to our the pre-restrictions or public health measures that were enacted in March. And this tells us that we continue to gradually increase our contacts in the community in terms of retail, workspaces, and transit, that we continue to have higher levels in our residential areas, meaning we're staying at home more frequently, and our groceries and pharmacy contacts have gone up back to pre-COVID rates. As well, we can see that people going to parks has increased, and particularly in the last couple of weeks, which is actually nice to see since the parks have opened again. So this is part of the information that gets fed into our dynamic compartmental modeling that we've talked about before, and this is the updated model that we've used to help us understand what we're doing, how we're getting along with the physical distancing, and help us understand what could happen with scenarios in the future. So this model it has our cases plotted against the model, and it does suggest that our continued declines in transmission, and it reflects the fact that we continue to pay attention to our physical distancing, to staying away when we're ill, to doing the measures we know prevent transmission in this province, and that we are continuing to track that in the right manner. So we remain around 30 to 40% of our pre-COVID contacts, and that's what we want to stay at. We want to stay somewhere around 50 to 60%, and we know that if we do that, we're likely to have low numbers of cases over time and not to have any exponential growth in our trajectory here in BC. And this is some of the projections from the modeling that tells us what could happen if we take away too many of our control measures, our protections, our safe distancing too quickly. So if our contact rate increases to 70%, we are likely to see a rapid growth. And 80%, we might see a rapid rebound in transmission in a very short period of time. So that is why we are taking our thoughtful and measured approach to our restart here in BC. And there are two ways that we can protect ourselves. One is by reducing the numbers of contacts, and we're talking about that with keeping our groups small, the importance of not inadvertently transmitting to large numbers of people, and we have seen some of that happening in workplaces, in family gatherings, even in the past few weeks. The other part is to ensure that when we do have those contacts, that they are protected, which means that we either have physical barriers, we have low numbers of people, we maintain our safe spaces, and we don't go into any place where we'll have contact with others if we're feeling unwell ourselves. Finally, I wanted to present a new type of modeling that we've been looking at over the past number of weeks, and it's what we call age-structured modeling. So it's based on real data about how different age groups interact in BC, and it was a model that was developed by BC CDC and UBC and a number of years ago to help us understand influenza transmission and things that might work in influenza. So our researchers have been working to understand how we can use this structured model to understand impacts of things like schools reopening. So this bunch of squiggly colored lines tells us quite a lot, actually. What it tells us is that we know that children, and we've talked about this, are less likely to get infected with COVID-19 for reasons that are probably related to the receptors, etc. But even if children were 100% susceptible, meaning that they had the same risk as adults of acquiring the illness, opening schools will have a minimal impact on transmission in our province as long as we continue to do the things that we're doing. So this is reassuring to us that even in the worst case scenario where children have the same rate of transmission as adults, that reopening of schools is not something that we would expect to cause rapid growth. As long as we are continuing, particularly adults, continuing to maintain our safe distances and to ensure that our schools are equipped to prevent transmission to the greatest extent possible. And finally, we also use modeling to help us say, okay, what's the worst case scenario? If this happens, what could potentially happen? So as schools reopen, and even if all schools were open and all children were in, if we relaxed our distancing measures, as long as we were fastidious about staying away if we are ill, whether it's children or adults in particular, then we still would be able to, we would prevent a rapid increase in epidemic growth. So these are the types of things that help us give evidence and data to support how we need to do things going forward. And these are the things that we will be following. We'll be following what's happening in schools over the next couple of weeks, and we'll be following the transmission patterns that we're seeing in our community over the second incubation period since our restart. And this is the data that will guide us to when we can move into the next phase of restart here in British Columbia. And I'm going to leave it. Well, I think I'll say one more thing. Just that, this our approach moving forward is really my new mantra is minimize, manage, and modify. So we want to minimize the number of new cases, and that means the things that we are doing and have in place now. We need to actively and very quickly, nimbly manage cases and clusters with rapid contact tracing, and that's the work of public health. And we need to modify our measures as needed, and that may be opening up things more, it may be looking at different ways of doing things. But we all know that we need to assess our risks every day, every step, and we need to follow our rules. We always, always, always need to stay home and away from others if we're sick. We still need to keep our connections and our contacts and our bubbles small. Not having large gatherings is incredibly important, and we've had a reminder of that in the last week where we've had somebody inadvertently and bring it into their close family, and we've had a transmission to a number of people. This is what we know from this virus, that we pass it on to the people we are closest to. And these are the measures that we need to take to ensure that we protect our families and our communities. We are all concerned about demonstrations that have happened that will trigger a surge in cases, and we're watching very carefully for that. I regularly speak with my colleagues across the country and to the south of us, and we are all watching these things. We know there continues to be transmission at a fairly high level in Washington State. We know that across the country we're continuing to see cases. So we are not immune to people bringing it into British Columbia. We know we have travel. We know we have travel into the province that's essential in many cases, and sometimes that can bring risk with it as well. So whether we are at work, whether we're thinking of participating in a peaceful demonstration, we need to continue to remember small numbers, keep our distance, and stay home, even if your symptoms are mild. And this is, no one intends to pass the virus on, but we know that when it happens, it's those closest to us who are most at risk. We all have a role to play in continuing our pandemic response in BC, and what we do today will make that difference for the coming weeks. So please continue to be kind, to be calm, and to be safe.
Thank you very much, Dr. Henry, and you'll know that the copy of the presentation for members of the public who are interested, and I know many people are, will be available both at the BC CDC website and linked to our statement today. So I encourage you to take a look at it in detail, look at the slides in detail. I'll just make a couple of points briefly about those slides. That, as Dr. Henry has said, one, it demonstrates why we have to continue to be, in particular, I think, vigilant at our borders. If you look at slide 4, it will show that in that period, that last 2-week period, which led into, I think in the slides, May the 29th, the last 2 periods covered in the slide, there was 144 cases over 2 weeks in British Columbia. That's roughly 10 cases a day in that period. In the last week, at the end of May and the beginning of June, there were thousands of cases in Washington State, in the thousands in Ontario, in the thousands in Quebec. Not so long ago, the largest outbreak in North America occurred at a business in Alberta. So what this tells us is that our measures and the importance and the continuing importance of measures involving quarantine and self-isolation when people return to British Columbia, Canadians return to British Columbia, are key. And measures at the border continue to be key for us as we maintain and avoid further transmission of COVID-19 in BC. Secondly, I think you see throughout these slides and throughout the results, from the discussion of contact tracing to the evolution of COVID-19 transmission in BC, the impact of what all the people watching us and all the other people, all of their neighbors in BC have done. The decisions that people have made on an individual basis have had an effect, and you have seen that in the flattening of the curve. You have seen that in the control of COVID-19 in relative terms in BC, notwithstanding circumstances. But circumstances occur. We talked about Washington State, and if you look at slides 11, 12, and 13, you see this. If you go back and look at the slides, you see that in Vancouver Coastal Health, where the early transmission occurred at the beginning, you'll know that the greatest number of cases were in Vancouver Coastal Health, and that was linked to transmission from Washington State, and that was linked to care homes. Still, the majority of deaths in British Columbia due to COVID-19 are in Vancouver Coastal Health. You see that the impact of this thing and why it continues to be our responsibility as a community and our responsibility as individuals to support one another and to ensure and to prevent transmission of COVID-19. And that responsibility and the needs for measures like restrictions on the size of gathering, the need for measures such as self-isolation and people returning to BC is as strong now as it has ever been. I wanted to update you with respect to 2 issues that we update every Thursday. The first is surgeries, and we have a very positive report about the extraordinary work being done in every single health authority in British Columbia. I just want to put it in context. In the high period of COVID-19, after we had fully ramped down and delayed elective surgeries. We averaged in that period from March the 23rd to May the 17th. We averaged in the period about 2,400 surgeries a week in that period. This past week, the week from May 18th to 24th, as you recall, that came up to 3,961 surgeries. This week, the number of surgeries was 5,174. And to put that in context, given the challenges with respect to productivity that COVID-19 brings in our acute care settings, we average around 6,000 surgeries in the pre-COVID period in a week, both urgent surgeries and scheduled surgeries, which are sometimes called elective surgeries. So we're getting closer to that number with 5,174 this week, and I wanted to congratulate everyone involved. I wanted to note that surgeries take place at 59 public facilities in BC, and elective or scheduled surgeries are taking place in all 59 now. They also take place in the public healthcare system under the Medicare Protection Act, the Canada Health Act, at 8 private sites. 7 of those are operating at full contracted capacity as we speak. The only one that isn't quite there yet is Falls Creek Surgical Center, which just rejoined us recently, and we expect them to be back with the rest of the system at 100% in the middle of this month. I wanted to just briefly update you on the single site initiative. There is some slight change in the numbers where we counted twice a site which had a long-term care facility and an assisted living facility. We've brought those together under one site. So we're now down to 526 sites. It was originally 545, then 533, I think, last week, and now 526. So it's fully implemented at 493 sites. Primarily the sites where it is not implemented, those 33 sites, the majority of those sites are assisted living sites. There are only now 5 long-term care sites in the whole province that have not implemented the single site plan. I just want to put it in context because that's the number of sites, but talk about how many workers we're talking about. There are 48,794 workers working at the impacted sites, the 526 sites. 39,576 were working at only one impacted site. So 8,878 workers were working at multiple sites, and that number now, those that have been assigned to work at a single site, is 8,495. So almost all, and the majority of the small number that have not been assigned yet are in assisted living, and those are primarily on Vancouver Island. And I think this is both an important step we've taken and a remarkable achievement that's happened in the context of COVID-19 in the last number of weeks. And it's because we made the decision to level up, as you know, hourly wages to union wages in accordance with the terms of this with single staffing. I know jurisdictions have proposed and even ordered single site staffing, but to make it happen requires ensuring that workers are treated both fairly and appropriately. And that's happened in BC. I think it's an enormous achievement. Those workers will start to see in the middle of June that reflected retroactively in pay, and they will be informed about those changes at that time. But from the time of the order where the single site was put in place at their facility, they will receive compensation accordingly. So in closing, today's session offers another powerful reminder that there are steps we can take to stop the spread of COVID-19. Single site staffing, that helps. Limiting international visitors at our border, that helps. Dr. Henry's measures, that helps. Maybe that even helps quite a bit. Aggressive testing and contact tracing, that is remarkable work. That is the everyday work of public health that we have come to acknowledge and recognize and maybe even celebrate just a little bit. But at the core of all these successful actions, at the heart of our success in BC, COVID-19, is us. Our success in stopping the spread, in moving through phase 2 and perhaps beyond, our success in keeping ourselves, our elders, and those we love rests on us. It still does. On our personal commitment to physical distancing, on our personal action to maintain it in the weeks and the months to come, on knowing we should stay home when we're sick and doing just that at the first sign of symptoms. There are a lot of things that others can do that shape the spread of COVID-19, but within our individual and collective power in BC, the steps we can take ourselves offer us the strongest protection and the greatest chance to stop the spread. Physical distancing, that saves lives. Staying home when we're sick, that saves lives. Coughing and sneezing into our sleeves, that saves lives. washing our hands. It saves lives. We've proven that we will take the actions necessary to stop the spread. What we might not think, but we need to know with 100% certainty, is that our actions save lives. That's our contribution, all of our contribution to our BC effort. That's what must be our conviction in the weeks and months ahead. That's what being 100% all in our COVID-19 effort means. Stopping the spread, saving lives. It continues to be true today.